Hello, everyone. This discussion here will cover endocarditis, pericarditis, and rheumatic carditis. We'll start with infective endocarditis. So review your layers of your heart. Know that this one affects the inner layer of the heart, or your endocardium. It's an inflammation of this layer. And what happens in here, I'll start with the patho, is if someone has, and risk factors, we'll kind of combine them here actually. The risk factors, we think about someone who has a damaged valve already, like a heart valve that's been replaced or repaired or needs to be repaired or replaced, because often these occur on the endocardium close to the valves or on the heart valves. This is common in our patients with valve replacements. Again, also we see this in IV drug users because their valves are not good from that constant turbulent flow when they do the IV drug injection. This can happen on any valve. With IV drug users, you'll see this inflammation of the endocardium happen on the tricuspid or the right side of the heart, because this is where their injected material enters into the bloodstream. So we see this also in patients with immune deficiency, if they had congenital heart disease, if they have an intravascular access device like a portacath, and rheumatic heart disease. And also we see this in patients after they've had their mouth cleaned, if they've had like extensive dental work done. So back to the patho, what happens here in this situation when someone has infective endocarditis, it starts initially with that turbulent blood flow from whatever cardiac defect they have. And that turbulent blood flow in the area of where the affected area, the endocardium and valvular problem is, it erodes a section of the endocardium. And then when the body senses this erosion happening, instantly our clotting cascade, our hemostatic system jumps in, and you will see platelets, and then all of those different clotting factors, ultimately fibrin, will adhere to this eroded area. And this will form a small little sterile fibrin clots at the area where it's been eroded. Often what happens is these different types of infection that I have listed here, the streptococcus and staphylococcus, these specific types, they're already in our normal flora, on our skin, in our nose, in our oral cavity. So somehow this bacteria will get into the actual bloodstream, sometimes dental work or IV drug use or whatever happens, it can get in very easily. And this bacteria will get trapped in the clots, that sterile clot area. It gets trapped in there, and it will ultimately cause what they consider and call a vegetative lesion or a vegetation. It doesn't look like a vegetable, but like it kind of looks wart-like, like it feels like a wart, but they call it a vegetative lesion. So that just means that it's platelets and fibrin and also bacteria all together. So as these vegetations grow, it calls more platelets and fibrin on top of that already growing vegetative lesion. And these particular germs here that are related to infective endocarditis, they're known to create what's called a biofilm or a biological film. It's a biological encasement, and that film covers and protects this lesion. So it continues to grow and get covered by this film. So platelets and fibrin and bacteria, they grow and like propagate and proliferate, and that makes it harder to treat. So eventually the endocardium and that valve that it's near gets destroyed. These vegetative lesions cause like holes in the area. It actually erodes the tissue away. So we see patients, again, with IV drug use and valvular issues are typically the people we see. Sometimes we see people without valvular issues and they went for dental work and it got into their bloodstream and somehow affected their valve. Often they have some type of valvular issue ahead of time, puts them at risk for this type of endocarditis. So what you'll see in your patient when you see your presentation, number one, fever. So we think of a high fever, we think of low grade fever constantly. Our older population, remember, they may not have a fever just because, they can't spike a fever as they get older. So we rely also on heart sounds. If we hear a new heart murmur, this is often the first sign too that the patient will develop. We also see these random things on our patients with infective endocarditis. endocarditis. Now, these can happen in other infective processes, but they're very strongly correlated with infective endocarditis. You see them in the picture there. We see Osler nodes, and those are painful nodes, and we see them on the fingers and toes. We see these Janeways lesions, and these are painless spots on the palms and soles. I'm sorry, if I said Osler nodes, they are painful. Janeway are painless. And then we can see splinter hemorrhages, which is in the fingernail there. We see them in the hands and feet, in the nails, little hemorrhages that look like splinters. We can see petechial patches, and the patients can often complain of, or rather report, fatigue. How we diagnose this? The American Heart Association recommends at least 3 sets of blood cultures from different venipuncture sites over a period of time before we start antibiotics. So lab can come draw a set, and draw another set, and draw another set. And depending on how sick they are, they'll draw them, closer in time, like they can draw them 10 minutes apart, or if they're not very sick, we can space them out over 24 hours. So it depends, but 3 sets is what's required. And these will show these type of organisms, either of the two. I've never seen both, but stranger things have happened. We will listen again for that worsening murmur and continue to listen to their heart sounds. Echocardiograms are very important in the diagnosis here. So they'll start with a bedside transthoracic echocardiogram. So that's the one that they just put on their chest when they're lying in the bed, and they can look at the structure of the heart. If the vegetation is big enough, we can see a vegetation in the TTE. Often, if there's suspicion for it and it's not really sure, if they can see it on the TTE, they'll go and do a transesophageal echocardiogram, because that looks more closely at the valves and what's happening in there. And we can detect a smaller lesion by doing these TEEs. So those are helpful tools for the diagnosis of infective endocarditis. We need to see that vegetative lesion, and then we go from there. Lab work, as you'd imagine, would include white count, because that will be high in patients that have infection and infective endocarditis, and also inflammatory markers like our C-reactive protein and our ESR or our SED rate can also be helpful in monitoring and tracking inflammatory markers over time and at our initial baseline when we find the patient has infective endocarditis. So that's helpful. As far as management, we'll treat non-surgically first. We always do least invasive before we do invasive. So that little biofilm and on top of that vegetation is very difficult to treat because, it's protected, but well protected by that biofilm. So after we get the blood cultures and we know what kind of germ we're dealing with, they will direct their, medications to fight that germ. We'll give them IV. It has to be IV. And it's a long course of antibiotics because this needs a longer kill time because it's hard to kill and it's high dose. So we're thinking 4 to 6 weeks generally for an infective endocarditis. So these patients will need long-term establishment of an IV, usually a PICC line. That's typically how we do it. But, again, think about your risk factors with that. We have patients that are IV drug users that now have access to an IV, an IV line that they can use. So we're careful to maybe try to keep them inpatient if we can. And if they are inpatient, make sure we're watching them at all times so they're not injecting things they shouldn't through there. And that's a very common occurrence, actually. So these patients will need to rest when they have infective endocarditis, and we're assessing them for the complications I've listed there at the bottom. As far as anticoagulants, we would think because there is platelets and fibrin and that clot on top of that, endocardium with those other germs in there that, you would not naturally think maybe it will create thrombus, and that will be treated with anticoagulants. But it's different. This type of infective endocarditis with this vegetation, it's not going to respond to anticoagulants. So that's not going to stop. Anticoagulants won't stop the growth of this vegetation. So the patients do not receive anticoagulants. Now, if they already have a prosthetic heart valve, and maybe that was the culprit that started this whole thing, maybe the bacteria stuck to that heart valve, they'll already be on anticoagulants for that heart valve. They will stay on those anticoagulants for that heart valve replacement. So it's not a standard of care, but if they're on them already, they will continue them. And that's how that goes. As far as surgical management, if they have a cardiac abscess on top or around that area that's infected, we'll have to drain that. They may need a valve repair or a valve replacement, depending on the extent of the endocarditis. And the complications are listed here. Most commonly, we'll see heart failure. So think of your right and left heart failure symptoms for your patient, and depending on that heart that's involved, the side of the heart, you'll see heart failure symptoms for them. We can also see embolic events because even though these aren't thrombuses, they're vegetations, they can still embolize and travel throughout our body. So we're always loma alert and looking for symptoms of infarction. So it can infarct areas like our spleen, our kidneys, our gut, and our brain. So we're thinking of stroke symptoms, abdominal pain, flank pain, splenic pain in that left upper quadrant. So think of where if a patient is complaining of pain or they have any change, that's the kind of thing that we're thinking about, complications like an embolism that traveled. For assessment for infective endocarditis, we're thinking, do they have a history of IV drug use? Can we provide some addiction counseling? Did they have a recent dental procedure? Maybe that will clue us into what happened there. Do they have a history of valve replacement? We're looking at their vitals, particularly their temperature. Focused cardiac assessment is we're going to hear a new murmur or a worse murmur than they had. Looking at those skin for those random things on there, including petechial patches, and we're administering our antibiotics on time, all the time, with our clean technique to prevent CLABSI. And also, you think about when you're giving long-term antibiotics, you're thinking about assessing for super infection and reporting those assessments to your provider, your physician, so that way you can get the proper treatment for the super infections. I'm thinking C. diff here, thrush, these are the things we're monitoring for. Interventions, as I mentioned, addiction counseling, where you have to talk about oral hygiene with these people, about they can't floss anymore, and they can't use like those water pick or irrigation devices because the bacteria, they're more prone to get infected endocarditis again. So we're talking to them about that and different types of oral hygiene they can use, usually a soft toothbrush, and there are other devices that are out there for patients that can't go, hardcore flossing on their gums. We're teaching them about care after they leave the hospital. Again, signs and symptoms of super infection while they're on antibiotics and what they can do if they notice any changes in their baseline status, like if they get more shortness of breath or any symptoms of heart failure, come in right away. Moving forward, they are going to notify their dentist of their history of infective endocarditis, or if they have prosthetic heart valves, they're probably going to need prophylactic antibiotics before procedures here on in so they don't get this again, because it can cost them their life. So we're careful with them. Okay, so pericarditis is the next one we'll talk about, and this is an inflammation of the pericardium. So this is, the heart is surrounded by the pericardium. It's also called the pericardial sac. This is a two-layered fibroserous membrane. You've learned about it before. The outer wall is the parietal pericardium. The inner wall is the visceral pericardium. And there is like pericardial fluid in between these layers to prevent them from sticking to each other when the heart pumps. So this inflammation of the pericardium can be caused by, often it's caused post-heart surgery or post-heart trauma. We see patients have inflammation of their pericardium. It's very painful after an MI. They call that Dressler syndrome. If they had post-cardiac surgery, like a cabbage, they may have pain in the chest after that, and it could be inflammation in the pericardial region there. Not as often will we see microorganisms causing pericarditis. We will see viral pericarditis more often than bacterial or fungal. So getting to the root of the cause is important for treatment. Some clinical manifestations we'll see are substernal pericardial pain. That happens in our patients. That's usually the first thing that they tell us is they have pain. It's sharp and pleuritic. Pleuritic means it's worse on inhalation, deep inhalation. And it's relieved by the tripod position, which is where you sit all the way up and lean forward, because that takes that relief off of that inflamed pericardium. You're kind of sitting forward so it's not pushing on anything. So we know that that's a good treatment for them, tripod position, like we do in COPD. And it's also an indicator. If they can't lie flat, we know they have an inflammation probably somewhere in there. So it helps clue us in. A big thing here is going to be this pericardial friction rub. So this is the sound, and you can click the link to hear it if you haven't before. It's made by the two layers of that pericardium when the heart moves within the pericardial sac. And the more the inflammation, the louder it sounds. We may have, if it's an infectious cause or an inflammatory cause, we may see fever in this population. That happens often. When patients, if this gets, I guess, progresses. It doesn't always progress, but sometimes it can create what's called a pericardial effusion. Effusion is fluid, so now we have a lot more fluid in the pericardial sac. If we start to develop a significant amount of fluid in that pericardial sac, we'll start to see more symptoms. In addition to the first clinical manifestations, we'll also see more orthopnea, more dyspnea. We'll see some coughing and some constant hiccuping from that irritation of the nerves there. Tachycardia due to decreased cardiac output. We can see diaphoresis, and we will see EKG changes. So we'll look on the EKG, and there will be multiple leads that have ST elevation, and also consistent with PR segment depression. So we think, oh my goodness, is this an MI? And we start to rule it out and look to see what else is going on with the patient to make sure it's not an MI. And so that's a little tricky there. So diagnostics, echocardiogram is very helpful here, and this will detect the pericardial effusion, how big it is, and its impact on hemodynamics. So is it affecting the pump? Is it affecting the blood pressure? Is it going to affect the pulse? And we're looking at signs of tamponade and inflammation, and we'll talk about tamponade here, which is in a little bit here, which is when the heart is completely constricted by fluid. A chest x-ray will help see an enlarged heart and potentially if there is a significant effusion. CT and MRI are helpful. They're not routinely done, but they can help. Echo is going to be your gold standard. But we'll look at the pericardium to help see inflammation and effusion if we're looking at CT, MRI. EKG, like I mentioned, ST segment elevations in many leads, and PR segment depression. Lab-wise, cardiac enzymes may spill a little bit, meaning we may have a little bump in our troponin, and if they check a CKMB, you may see a little rise in that, but nothing quite like the levels what we'd see in an MI. So that helps to differentiate the two. If the patient does have, if this is a bacterial pericarditis, then we'll see positive blood cultures, and we would of course get those when they're ordered to rule that out as a cause. And because this is an inflammatory process, we're going to trend our white counts and our inflammatory markers. Management is going to include several things for these patients. So we think about, again, position of comfort. So sit them up and lean them forward. That helps. Drug therapy they use are things like Motrin and Advil, because these will reduce inflammation and pain and make it a little more tolerable for them while this is happening, because it's often several weeks of pain, and some patients have a chronic pericarditis, so we want to treat that pain and then watch it and see if it progresses into something more serious like an effusion and cardiac tamponade. So we're monitoring these things. We're giving them NSAIDs for pain. Of course, we're looking for GI bleeding because they're on NSAIDs, and we're not going to give these to patients that don't qualify. Like if they have renal disease, we know that we can't give NSAIDs. Colchicine is another drug. They may use it by itself. They may use it with NSAIDs. It all depends. Remember this medication from when you learned about gout. I'm sure it's an anti-inflammatory, and it's often used, with the NSAIDs. Data has showed that colchicine, when they combine them together with the NSAIDs, they can improve the response and the treatment and prevent recurrences of pericarditis. So this is something that they think about. Position for comfort, sit them forward. They may put in a pericardial drain if the patient has enough fluid and they're continuing to experience lots of fluid in there. So this little drain will connect their little, they'll put a slot in the pericardium and they'll make a little drain that either comes external to them in the interim, or they can do something where they put a drain that drains the extra fluid from the pericardium into the pleural space. So that helps to prevent it from building up in the heart. And so we use this for more of a chronic type pericarditis. If it's a really bad pericarditis where it's causing what we consider to be constrictive pericarditis, then we can do something more invasive like a pericardectomy, which is not real common, but they can take away part or all of the pericardium. So this is when someone has had pericarditis routinely and they have a chronic case of it, and the pericardium becomes thickened and scarred and it leads to a compression of the heart. Then they may need to operate and do the pericardectomy. Okay, so a complication I alluded to a moment ago is called what are we talking about here? Cardiac tamponade. So that is when our pericardial effusion or the fluid between the pericardial space becomes So it accumulates to the point where it's exceeding the typical 15 to 50 milliliters that we see in the pericardium. So it's growing bigger and bigger, and it starts to compress on the heart. It places the patient at risk for decreased cardiac output and PEA and death. So when we see a patient that has cardiac tamponade, we're jumping in right away if we start to see any of these symptoms and they have a risk factor like pericarditis or whatever else can cause pericarditis. Symptoms will include JVD, that's a major one, and that will stick right out at you, but the patient will not have crackles because this is caused by that compression on that heart. We may see what's called a paradoxical pulse or pulsus paradoxus, which is a classic sign you'll see mentioned in terms of the assessment of cardiac tamponade. So what happens here is because the heart's constricted by the fluid in that pericardial space, it has a harder time filling with blood during inspiration. So when you take their blood pressure, you'll see an exaggerated fall in their blood pressure during inspiration. So more than 10 millimeters of mercury, it will drop during inspiration. So you'll see that difference. You can also see a narrowed pulse pressure. Remember, your pulse pressure is the difference between your systolic and diastolic pressure. It's usually about 40 millimeters of mercury, but when it becomes narrowed, it'll be like less than 25, and that can be a sign of cardiac tamponade because the fluid in that space is restricted. It's restricting the heart from filling properly. Big changes in vitals we'll see. Hypotension, because the heart cannot expand and can't do its usual pump action. So hypotension is huge here, and tachycardia is going to go faster in order to compensate for this constriction. When you listen to their chest, you'll hear muffled heart sounds. They may start to have altered level of consciousness, fatigue, of course, dyspnea they'll have. So these patients will need an emergent, this is a medical emergency when this happens, they will need an urgent pericardial centesis, which is where they put an actual needle, so a 16 to 18 gauge needle commonly, into the pericardial space. And that will urgently remove that fluid that's in there. They'll put a catheter inside of it, and then they'll withdraw the fluid. They don't just do it with a needle. They'll put a catheter on top of it, and they'll drain it temporarily. And this is usually performed under fluoroscope, although I've seen it many times during a code, because you think about your 5 H's and your 5 T's. If you need an emergent pericardial centesis, you're going to use the needle and take that fluid out just to see if it helps, if that's one of the reasons that they're having PEA or asystole. So we're thinking of those things. After the procedure, make sure the patient is not developing infection, bleeding, or if that tamponade, it can come back because we have to think about what caused it in the first place. Sometimes patients will continue to have it again and again, and you'll have to watch them and report it until they can get to the bottom of it and things. So they're always at risk if they've just had the pericardial centesis. So we're thinking of those things. It may not resolve the issue, in other words. When you see the pericardial centesis, of course, we're going to have our crash cart there. We're going to have patent IVs ready for the patient, and we're going to be monitoring vitals as well as heart rhythm. After the procedure, we should see that the patient's blood pressure comes back. It's wonderful. Their tachycardia, slows down. This paradoxical pulse is gone. The pulse pressure is better. The JVD goes away. The heart is more clear. So all of these symptoms will resolve, but we're checking for them to come back because this can reoccur. We don't want that. So we're careful to pay attention. Nursing, as far as our management, we're going to listen for those heart sounds during and before and then after, monitoring for recurrence because that happens. We're going to give them oxygen if they need it. If they're anxious, which I'd imagine they would feel that way, give them medication if it's ordered, and do other techniques that you can to supplement and be adjunctive to the medication. Let the doctor know right away if we're suspecting recurrence or initial cardiac tamponade. Patients should be on bed rest when they have this because you don't want to increase the workload on the heart. For patients that have recurrent or like a chronic pericarditis with a recurrent tamponade, recurrent effusions, this could be acute actually or chronic. A patient may qualify and need what's called a pericardial window. So this is like they'll take again a piece of that pericardium away, and this will allow fluid to drain into the pleural space. And sometimes they'll do other spaces where it can drain just so it's not draining on the heart. This is a surgical procedure. And patients that have chronic constrictive pericarditis, which is, constricting their cardiac output, you may see them get that pericardectomy that I mentioned. Not real common, like I said, but, it's a treatment that we can use. So Okay, so we'll talk next about rheumatic pericarditis, which the takeaway message I have written down here. So we don't see this as much here in America anymore, so we'll talk about it briefly. This is when someone has untreated strep throat or untreated scarlet fever. It's caused by that group A beta hemolytic strep bacteria, and it can affect any parts of the body, and it causes rheumatic heart disease, which damages the valves, can lead to heart failure. I'm sure you learned about that in patho. Rheumatic carditis is like a particular manifestation of rheumatic fever that affects the heart. It causes things like, and it affects all layers of the heart. And it particularly causes chest pain, breathlessness, palpitations, and signs and symptoms of heart failure. So review again your right and left symptoms of heart failure. So that will be helpful for you to determine where it is and if it's getting worse. And it, again, all layers of the heart can be affected, and it could lead to a new heart murmur if they don't have one already, or a change in their heart murmur. Tachycardia can happen when they have this, heart failure symptoms, and we can also see a pericardial friction rub because this is all of the layers of the heart that is affected. What we do to treat it, typically like a penicillin or an emicin, long, 10 days typically. If they need antipyretics because they have high fever, we'll give it to them. And then we will encourage fluids, of course, because if they're febrile, they will be losing fluids and breathing fast. So they'll lose, volume through insensible loss. Rest important for them. We don't want to increase that workload on the heart. Anti-inflammatory medications, like we talked about for the other disease processes, like NSAIDs, is helpful. And if it is a pericardial inflammation, they can get that colchicine too. Sometimes heart failure medications, depending on what their symptoms are, after when they have the rheumatic carditis. So we tailor the management plan to this patient. If they're having, heart failure, we'll treat the heart failure. Key message again here: if someone has strep throat when they're, going through life, or they've had scarlet fever or whatever, if they have it, treat it right away, and you'll prevent this whole rheumatic carditis from happening, and then they won't develop that rheumatic the rheumatic heart disease that causes all of these other things to our body. So we're doing really good here in America. Our rates are down of rheumatic carditis and rheumatic heart disease because we're treating those strep infections quicker. So that's great. So we need to just keep the pace and do our education as nurses to prevent it in the first place. And I think that's all we have. And thank you. If you have any questions, please post them to the discussion board and let me know. You can email me too. Have a great rest of your day.